Okay, this is a cool case of a partial rotator cuff tear. This was a 13-year-old right-handed athlete with really chronic shoulder pain. He was a baseball pitcher, and essentially he'd had this pain for 20 months, in the lateral sort of anterior shoulder. He had pitched through it until he felt a pop and it got worse. He did 8 months of physical therapy and NSAIDs without improvement. He resumed baseball but could not pitch, and he's presenting to the clinic now with persistent pain with any overhead or throwing motions. He has no numbness or tingling, and the pain does not radiate down into his elbow or down in his lower arm or into his neck. On physical exam, he has grossly normal body habitus and muscle tone. He has no focal tenderness. He has an internal rotation deficit compared to the left arm. His strength is intact. However, he has a positive Neers test, Hawkins test. He has asymmetric strength with his resisted external rotation test, a positive empty can test, and then the labral instability testing, pardon the typo, are normal. On the right side of the screen, it's a good illustration of, at least on the anterior shoulder, what your palpation and bony landmarks are. So starting immediately, you have the sternoclavicular joint. I always walk from there. I walk across the clavicle over to the AC joint. I palpate the AC joint and I walk across the acromion and I walk it right posteriorly into the spine of the scapula. The coracoid process is a good bony landmark, and then the greater tuberosity, essentially the lateral shoulder there. And then on the posterior side, you really want to walk along the muscle bellies of the scapula, as well as the medial scapular border up towards the neck. He had an x-ray which was normal. And here, we'll review the x-ray right here. He had an x-ray which was normal. This one is labeled. You can tell it's a teenager, is skeletally immature, right? The growth plate is open in the humeral physes here. You see the clavicle coming medial to lateral. You see the acromion process. The AC joint not well visualized here, but it is patent. You see the humeral head articulating with the glenoid. Okay, these are articulating. Glenoid fossa is here. Humeral shaft is coming up, and then you can sort of see the silhouette of the scapula, including the lateral border here. So basically a normal x-ray, nothing stands out. In the case of rotator cuff injuries, you're looking around the humeral head for any pathology. So his x-rays were normal. He had an MRI early on in his care course, which showed a high-grade abnormal signal in the supraspinatus tendon with a near-complete partial tear. He wasn't getting better, right? This is 20 months ago. So now he's had a second MRI, which shows a high-grade partial thickness bursal surface tear of the supraspinatus tendon, which basically didn't look like it had improved or was getting better compared to the prior MRI. His final sort of workup to confirm what was going on is he had a diagnostic injection into his subacromial space, and this is a good illustration of how to do that. So on the left side of the screen, we see the spine of the scapula wrapping around into the acromion. We see the humeral head here. Then we see the rotator cuff muscles being sort of simulated by this rubber component. And then the blue part here is the subacromial bursa, right? So you're basically palpating on the screen just below the subacromial bursa, just below the acromion, and then you're marking the skin, and then you're injecting and pointing towards the coracoid process. And in this case, they're injecting steroids. That's why it's kind of milky. But in the case of our patient, it was just lidocaine anesthetic to confirm where the pathology was coming from. Let's talk about partial rotator cuff tears. One of the most common causes of shoulder pain, accounting for rotator cuff pathology, accounts for at least half of all shoulder pain. It can be acute or chronic, more likely chronic. It can be traumatic or atraumatic, more likely atraumatic. Typically degenerative or overuse, like in our case, is this a baseball pitcher. Rotator cuff is 4 intrinsic muscles of the scapula that help with all planes of motion in the shoulder girdle proper. That includes the supraspinatus, infraspinatus, teres minor, and subscapularis. On the illustration to the right here, you see some of those. You're basically looking at the back of the shoulder with the scapula and the humerus illustrated. And from top to bottom, you see the supraspinatus muscle coming over the top and hitting the top of the humerus here. And you see infraspinatus, right? Infra below the spine, infraspinatus, and teres minor coming over and attaching on the lateral side of the humeral head as well here. And then on the front of this, if we had another illustration, you would see subscapularis on the front of the scapula wrapping around the front side of the humerus. On clinical presentation, the vast majority of patients have shoulder pain. They may have weakness, especially if they have a complete tear, typically gradual, localized to the lateral shoulder, worse at night. You want to do your typical shoulder exam, right? You want to inspect, you want to palpate, you want to do good range of motion testing and strength testing because your differential remains broad even though you suspect rotator cuff initially. There are a lot of special tests, way too many to present here, but common ones include the empty can test, Hawkins, Nears test, and painful arc test. On the right side of the screen, we see an illustration of the empty can test. The patient has flexed his shoulders forward to about 90 degrees with the elbows extended. His thumb is pointed towards the floor, and then he is externally rotated about 30 degrees. He is pushing up towards the ceiling while the examiner is resisting that upward motion, which is essentially firing his supraspinatus tendon. In the case of our patient, this was positive. Evaluation, radiographs pretty much for any orthopedic condition, right? Typically normal in this case. However, some findings can suggest rotator cuff disease, which would be a decreased acromiohumeral space, right? So the humerus and acromion have less space in between them. The humeral head can actually sublux all the way up to the acromion. There can be a hooked acromion, which you can imagine is kind of chewing into the supraspinatus tendon. Degenerative changes, and then sometimes you see calcific tendonitis, which is sort of a different pathology that presents with rotator cuff pain. MRI, of course, is the gold standard. Can assess for tendon defects, retraction, look at other associated findings like bicep tendon injuries. This is a great MRI in the coronal plane showing the glenoid socket here, humeral head. These are labeled, right? And then you see what would used to be the supraspinatus was attached here. It has completely torn, right? So this is the insertion site, kind of irregular in appearance. And you see the tendon has actually retracted, and you see all this fluid here. So you have this complete tear with retraction of the tendon and significant bursal effusion here. Not a significant joint effusion, although there is some signal here as well. This is the deltoid sitting over the supraspinatus tendon, or where it used to be. Treatment is generally not operative for incomplete and chronic partial tears in anyone who is not a good surgical candidate. And initially, that includes rest, physical therapy, corticosteroids, NSAIDs. There's a lot more nuance to it, but that's sort of the gist of it. Operative indications are typically acute tears in young, healthy athletes and chronic tears that are not improving with conservative measures. For young, healthy athletes, you can hopefully do a primary tear. That's the best case scenario. In chronic cases or complete tears, you need a reverse total shoulder arthroplasty, which is a whole different beast. And then sometimes, if there's an acromial pathology, you do subacromial decompression, and sometimes you have to actually debride the rotator cuff in general. In the case of our patient, he essentially did not improve with 20 months of conservative management. That's over a year and a half, right? That's a long time to try to do non-surgical management, and I understand why that was pursued. Ultimately, they decided to proceed with arthroscopy, and he ended up having a debridement of the undersurface of the frayed supraspinatus, repair of the bursal surface, and release of the coracoacromial ligament. He was in a sling for about 3 weeks with passive movement only, slowly advancing his active exercises. He eventually regained full active range of motion. He began a limited throwing program at about 3 months, and about 6 months had returned to full active baseball and football with no restrictions. And at his last 9-month follow-up, he was doing great. He had no symptoms and no issues. So 3 key points about partial rotator cuff tears. The most common cause of shoulder pain, typically impacting activities of daily living, occupation, sports. Diagnosis is primarily clinical. You usually know what's going on with a good history and thorough physical exam, but of course, MRI and sometimes ultrasound will confirm that diagnosis. Most tears can be managed non-surgically, although refractory cases and in certain patients like ours, surgical intervention can be pursued.